presentation for the CSD 513 final exam will be on Wernicke's aphasia. I'm going to discuss what is Wernicke's area, who discovered it, where is it at. I'm also going to talk about the etiologies. I'm going to talk about the assessment, the intervention, and treatment of Wernicke's aphasia. So let's get started. Wernicke's area was discovered by German neurologist Karl Wernicke. Wernicke's area is traditionally thought to be in Brodmann area 22, which is located in the posterior portion of the superior temporal lobe. It is involved in the comprehension or understanding of written and spoken language. So damage to Wernicke's area results in receptive fluent aphasia. This means that the person with aphasia will be likely to fluently connect words, but the phrases they produce will lack meaning. So let's talk about some of these etiologies. Wernicke's aphasia is classically associated with a lesion to the posterior portion of the superior temporal gyrus, also known as Brodmann's area 22. Recent research has shown that actual associated areas of the brain affected in people with Wernicke's area include not only Wernicke's area, but other parts of the temporal lobe, such as anterior portions of the temporal lobe, posterior middle gyrus, the posterior superior temporal sulcus, as well as parts of the inferior frontal gyrus, including Broca's area, the middle frontal gyrus, and the dorsal premotor cortex. That is a quote from Donkers, Wilkins, Van Valen, Redfern, and Jaeger. Blockages, lesions in the smaller posterior branches of the left middle cerebral area causes Wernicke's aphasia as well. Stroke is also a potential cause of the condition because it impairs blood flow to the brain. So what are some characteristics of Wernicke's? The person who is diagnosed with Wernicke's aphasia often produces jargon or nonsensical words or phrases when attempting to speak. There is a major impairment of language comprehension, while speech retains a natural-sounding rhythm and flow and a relatively normal syntax. Auditory and reading comprehension is moderately to severely impaired. Oral and written expression is moderate to severely impaired as well. So the first part of assessment that we go through is screening. Aphasia is usually first recognized by the physician who treats the person for his or her brain injury. Most patients will undergo a magnetic resonance imaging, or an MRI, or computed tomography, a CT scan, to confirm the presence of a brain injury and to identify its precise location. Screening does not provide a detailed description of the severity and characteristics of aphasia, but rather it is a procedure for identifying the need for further assessment. Screenings are an important first step in determining the need for treatment. Screenings can be standardized or non-standardized to assess the oral motor functions, speech production skills, comprehension and production of spoken and written language, cognitive aspects of communication, and hearing. So I attached at the bottom some examples of language screening tools, and you can read those. Typical components of aphasia assessment, first off, is the case history. Under the case history, we would be discussing the medical status and medical history, education, occupation, cultural and linguistic background. We'd have a self-report section where we looked at functional communication struggle and success, communication difficulties and impact on individual and family/caregivers, context of concerns, language used in context of concerns, goals and preferences of the individual, oral motor examination. Our oral motor examination portion of our screening assessment would look at differentiating between language-based and motor-based deficits by assessing the strength, speed, and range of motion, sequential versus alternating movements of repetition, and we use like diadokinetic rates for that, steadiness, tone, and accuracy of movements for speech and non-speech tasks. In the language portion in the language portion of our assessment, we assess expressive, which is going to be speaking and writing, and receptive, which is listening and reading skills in spoken and written languages across a variety of contexts, so in social context, educational context, and vocational context. And what's neat is in these skills where we're looking at their written and their verbal speech, we see that writing mirrors speech output. And at the bottom here in the images I have attached, they correlate with those language screening tools. So they're very useful. Assessment results. Assessment may result in one or more of the following: diagnosis of a language disorder, description of the characteristics, severity, and functional impact of the language disorder, prognosis for change in the individual or in relevant context, recommendations for intervention, support, and community reach. And now we're going to start talking about treatment. So, like I said, I'm talking about Wernicke's aphasia, and only 13% of all people who are diagnosed with aphasia have Wernicke's aphasia. Thus, there is significantly less attention in the medical and SLP literature than for anterior or anomic aphasias. So it's important that we use good evidence-based practice for this, and so intervention and goals are designed to capitalize on strengths and to address the weaknesses related to underlying structures and functions that affect communication across partners, activities, and settings. Facilitate the individual's activities and participation by teaching new skills and compensatory strategies to both the individual with aphasia and his or her spouse or family, and incorporating AAC strategies if appropriate. Treatment approaches. So, treatment approaches can be restorative, aimed at improving or restoring impaired function, or compensatory. Best practices in intervention. First, some of the best practices for in intervention is to embrace communication as a human right. Recognize assessment as an ongoing intervention process. Include family members, caregivers, and others whose roles are relevant. Have a clear sense of purpose and goals. Engage communication partners outside of the client's immediate circle of friends and family. Encourage self-coaching. Focus on functional communication. Focus on abilities the individual needs and wants to improve. Focus on relevant material. Focus on strengths. Be an interdisciplinary team player. Use evidence-based approaches. Encourage aphasia-friendly communication. I think those are great tips and very, very important to keep in mind when we choose goals and treatment interventions for our patients. Treatment options. One of the first treatment options is context-based management. Community support and integration. Community aphasia groups. Treatment and support for people with aphasia can improve linguistic functioning in a naturalistic setting and enhance social networks. Groups offer individuals and family members an opportunity to socialize, converse, share ideas and feelings, receive support, and learn more about aphasia resources. Computer-based treatment. Computer-based treatment involves the use of computer technology and or software programs to target various language skills and modalities. Several currently available programs generate data about the individual's progress on specific tasks. These data can be used in clinical documentation. An example would be using the app for item identification drills. And in those item identification drills, we could use systematic cueing such as word retrieval cueing strategies where we provide additional information to prompt word recall, which with aphasia is a communication boards. Communication boards are patient-specific and may assist a person with Wernicke's aphasia by using a real-time reference to graphic symbols and can increase the comprehension, orientation, functional understanding, and participation of individuals with severe intellectual disabilities in meaningful daily activities. Another activity that I have personally used is News to You, where it is a story and it's broken down, and you can have it at different levels depending on where the client is that week. And it has a graphic image that correlates with each word of the story. So you can start out the first couple of sessions by only having the graphics and the words, having every graphic for every word, and going through the entire story and using the graphics and the words to read the story. And then as you progress through your hierarchy, you use less of the graphics and you increase the ability to increase reading comprehension, increase automatic speech drills. Automatic speech drills improve correct fluency or allow more voluntary control by tapping into long-term procedural memory. Some examples listed here are counting from 1 to 20, naming days of the week, naming months of the year, saying the Pledge of the Allegiance, saying the ABCs, sing Happy Birthday, answer the phone, knock on the door, not answer the door, complete common sayings, sing musical nursery rhymes, complete and phrases, and complete verb phrases. These are a list of the references that I use to collect this data and information for my presentation today. I hope you learned something and I hope you enjoyed it. Thank you.